All right, I think we're ready to go. Again, my name is Sarah De Silvi. It's my honor to welcome you to the February 22nd public terminology call. We're going to be doing some updates and also addressing utility and security concepts as part of our utility and security concept build for the winter spring 2024. Next slide. Again, thanks for joining. We do have everyone muted upon entry. And we, just because of the large number of attendees or how it can swell to a fairly large number of attendees. But we do have a fairly robust conversation throughout our call. So even though you're muted now, we'll make sure that we center any questions or concerns you have. The call's always recorded, and recordings are always available on the Confluence after the meeting for posterity's sake. If you want to participate in chat in the moment, we really are trying to be more of a seminar format. So if you have something to say, put it in the chat to everybody, and then we'll try to make sure we address your concerns as we go forward. Again, the to everyone is really critical because we want to make sure that everyone sees your comments and we can have a robust and consensus-filled conversation. Next slide. This is the common antitrust practices slide. We've addressed this now a couple times, so I'm just going to do the high-level elements. Gravity project participants have the responsibility to comply fully with federal and state antitrust laws. Individuals speaking or providing written communication shall refrain from any discussion which may provide the basis for an inference they've agreed to take any action relating to prices, services, production, and allocation of markets, or any other matter having a market effect. And then the following two participants shall not discuss their pricing or others' pricing. And then we just make sure you follow these guidelines in order to have, a compliant conversation publicly. Next slide. There's a lot of me talking, but our SMEs should join as well. And as always, we hope it's not just me, just because I'm the presenter. We hope to have a collective conversation. Next slide. The next slide. We have some pretty exciting announcements over the course of the next slides, and there's an element in our next announcements that's actually building off some conversations we were having in the previous meeting. So first of all, on the 28th, which is very shortly next week, Gravity Project is inviting everyone for a kind of annual update, February 28th, 12 to 1 p.m. Eastern Standard Time. It's going to be a webinar that will review and celebrate our collective progress during 2023. It's going to feature an organizational overview and accomplishments, a discussion of Gravity standards, highlight real-world implementations, including the New York pilot and implementation workstream accomplishments. It'll look ahead to the comprehensive roadmap for 2024, which you all as dedicated terminology members are aware of. It also will talk about how to engage with Gravity. You can register at the link, and Sarah Bahal has put that in the chat if you'd like to register. Just an orientation to our other two work streams within Gravity. The technical work stream continues to meet bi-weekly, Wednesdays 1 to 2 Eastern Standard Time. You can find those meetings on the HL7 calendar. And the pilot and implementation work stream kicks off for the 2024 year next week again on Thursday. We have a pretty great topic next week. The registration for that is there's a Zoom on the Confluence for accessing the meeting, and the registration is currently through our partner in implementation, Civitas, but the Zoom again is always on the Confluence if you want to put it on your calendar. It is 2:30 to 4 Eastern Standard Time on next Thursday. The topic is a very interesting topic on different methods of screening, documenting screenings aligned with FHIR that come from the New York implementation, talking about observation versus questionnaire response, and how that relates to the all-state implementation of the New York waiver and our work with our HIEs there. So if you are FHIR curious and want to know about how the New York pilot's addressing that, then please come to the implementation workstream meeting next week. Next slide. And again, all the topics of all those things are on the Confluence. We are super excited to say that the long-awaited, ever so critical social care co-design final report is finally available on the Confluence. I brought this up in our meeting a couple weeks ago. We were talking about assessment. So the Social Care Co-Design Project was a joint project of Gravity and Civitas Networks for Health, again, through our implementation partnership with support from the Robert Wood Johnson Foundation. It had six session series completed in August through October 2023. Again, the intent was to really center social care expertise, to solicit, synthesize, and document social care and community-based organizations' feedback and insight to inform Gravity's data standards evolution, right? So the evaluation and evolution of our terminology and technical standards to ensure that we better met social care needs. The report is available on the Confluence. It's in the technical work stream under like as a parent-child. If you go to the technical work stream, it's a subset of that. It's also dropped into the chat, so you can find it there. I am centering this here, number one, because it was released on Tuesday, but also because we had a fair bit of conversation a couple weeks ago on social care perspectives on the term screening and the term assessment. And I mentioned that the report would help us find a path forward that really centered social care expertise and how Gravity use cases can evolve to meet social care expertise. And I'm going to talk about this over the course of the next couple slides, again, just building off of what we talked about last time. Lucy could not be here today, but we're recording the webinar so Lucy can catch up because she raised this really critical question last time. So on the left, you see a model. This model has been, disseminated. We presented it at the WEDI conference this week. We've been showing it in many different stakeholder situations. I'm going to orient you to the model very briefly, and then I'm going to talk about the assessment components on the next slide. So if you look at the blue circles on the model, screening, social risk assessment, and intervention, the goals are not here, but if you have screening, social risk assessment, and intervention referral and intervention coordination provision, those are all base Gravity use cases and activities that we have done our work around. We collate screening instruments, we developed social risk diagnostic statements, we intervene on social risks, right? So those are all things that we've leaned into pretty effectively over the course of our 5 years. When we gathered our social care friends and our experts to help guide us, they revealed opportunities to lean into additional use cases that we've not fully developed yet, that were critical for understanding how they do what they do and how the requirements that they work within. So everything in green is an additional use case that they asked us to lean into and consider in order to better meet the needs of integrated and supportive social care. This includes additional elements within assessment. And again, all of this is available in the report. Additional kinds of assessment, including holistic assessment and acuity assessment. And I will describe what those are later. It includes not just goal setting, but actively care planning. This is why goals are not on here, even though they're a current activity. It includes coordination and collaboration across the health and social care ecosystem. It includes centering, assessing eligibility and CBO and social care capacity to deliver services. It includes centering reimbursement and investment in social care service delivery. It includes individual outcomes evaluation, like are the interventions and our actions helping the individual person. But it also necessarily includes population aggregation on like a population level. Because as we've said from Gravity from the get-go, although we might identify needs at person level, the changes and the solutions are primarily structural if we want to address the upstream drivers. So each of these additional areas were assessed and defined by our social care experts and prioritized in order to drive further Gravity work. And you can see why I brought this forward, because not only, again, is the social care co-design report released, these elements of additional assessment directly relate to our conversation a couple weeks ago on concerns for the simple activity of screening and the simple activity of documenting one IC10-CM diagnosis and how it doesn't represent the complex, holistic, and policy-driven assessments that happen in social care settings. And I'm going to go a little bit more into that in the next slide. And if you can feel free to ask questions or read the report, it's really a beautiful report. I just want to, again, I don't see it on this slide, but Thanks again to our friends at Health Begins who helped facilitate the co-design sessions. We couldn't have done it without them. All right, next slide. So again, I'm pulling this slide forward because it's a direct outgrowth of the conversation on screening and assessment that we had 2 weeks ago. So when we think about putting these things again, like centering social care and defining these activities themselves, because the Gravity team was essentially just facilitators in this. This is the way they asked us to think about them, to center the labor and expertise required for these different types of things. So screening is that, prevention, population level activity to identify unmet social needs. Again, it's not always population level. Sometimes you can screen individual, but generally that was the approach they asked us to consider. Social risk assessment is evaluating a presenting need rather than a full holistic assessment, right? So that is what we were talking about the limitations of at our last meeting. Like one IC10-CM code for food insecurity is not a holistic assessment. The episode of screening has limitations, right? And so again, those are blue circles that are contained in our previous use cases. They're part of what Gravity has addressed in the past. So when we think going forward, they asked us to consider these things. One is the activity of holistic assessment. And this is an expert-driven activity. It can happen in both social care and clinical settings. We think about the role of social workers in clinical settings. And it needs to be supported and valued accordingly within the social care model. We heard this very clearly. So holistic assessment is a robust, comprehensive assessment of social, physical, emotional, and ecosystem context to identify risks, needs, strengths, and supports toward the aim of establishing priorities and goals, right? So this is, when we think about the role of community health workers or social care experts or social workers or care managers. These are things like doing eco maps and understanding important people, understanding strengths as well as understanding risks. We've included strengths-based assessments in our model in Gravity, but holistic assessment really creates a place for them. And just, again, defining this, centering this as a critical activity and really part of effective social care was an outcome of the social care co-design process. The next one is another type of assessment, and this is really critical when we started to listen and learn from our social care experts on how they triage needs and the expectations that they are bound within in care delivery. So this is called acuity assessment. It's an assessment of urgency or acuity to assist social care entities in prioritization of resources. From a clinical perspective, we think about this as triage. There are certain social care service delivery agencies, such as a community action agency or a housing agency and a continuity of care system, that are required to do acuity assessments based on policy. They cannot deliver care unless they do a social risk matrix, unless they do a HUD intake called a VISPDAT, right? And this is a comprehensive list of all of the social risks this person's presenting with. The reason why that's required is because those entities have to triage resources within a system of scarcity, right? So if you only have limited housing, you have to do an acuity assessment to understand who gets the house first, right? And so these new kinds of assessment, again, long-standing in practice, but newly named and centered as use cases in Gravity, are important. They fully pull in the concerns that we heard a couple weeks ago on our last call. And now that the social care co-design report is out, we not only have a way to point to them as something that's being named as important, we actually are in Gravity prioritizing action in building standards for and supporting these use cases on our roadmap. And it's pretty exciting. Any questions on these definitions? Again, there was concerns raised a couple of weeks ago. I said the social care voice co-design report was coming. Luckily, it's released and available on the Confluence, and we can see these needs being centered from the social care experts. Any questions there? Or does it just like echo and support what you know to be true? It sounds like it does that. I'm now going to talk about just briefly how we can see these use cases on the previous slide being centered on our roadmap. Next slide. So I wanted to state, like, the moment these use cases came out of the Gravity Social Care Voice co-design process, we started bringing them to our leadership committees in order to get prioritized as new use cases, because that was the whole intent, right? Help us direct new exploratory work to support what you do. So starting now, starting a month ago, and lasting through the spring, we have member-led discoveries on a couple of those use cases that matter to them, to the social care entities, centering again many of the same social care voices in leadership of those use cases or in the gathering and development of those use cases. And the two primary use cases that came out of that initial prioritization were reimbursement and investment for social care payment and reporting, and interventions, outcomes, evaluation, and management. So again, these were social care elevated, sent to the leadership committees, prioritized, and now social care experts are helping us frame and craft a path forward. I want to note again, and I think this is on the next slide, if you look at the interventions, outcome, evaluation, and management use case, this is something we've been talking about, again, for a very long time. I talked about it on the co-design report slide, but if we go to the next slide, next slide. I'm just going to land here for a second, because although that outcomes and evaluation use case was independently prioritized by the Social Care Voice Initiative, it's been our third use case on our roadmap since our inception of our project, right? We haven't leaned into it per se, but from the beginning, Gravity's always conceptualized 3 core use cases that really break down into other specific use cases within the implementation guide. But that first use case is documenting social care data at patient-client encounters. That next use case was tracking social care interventions to completion. And again, those are person-level activities. And we've always landed on the last use case is gathering and aggregating social care data for uses beyond the point of care. So this is again for purposes of population health, quality reporting, risk stratification, research, and policies to foster health equity, right? So coming out of our social care voice co-design project, that was re-elevated, both looking at outcomes and evaluation on the person level, but also outcomes and evaluation on the population health level. And you can see that evaluation and outcomes use case being one of the first 2 priority use cases we're focusing on in Gravity as we look to new work. Whew. I think that's okay. Next slide. This is our member slide, and we're so grateful for all. I know, Denise. This our 2024 members. We have a lot of wonderful new members that are coming into the work, longstanding members who've supported us from the get-go. All of that work of prioritization is driven by our members who are both, members who are supporting us financially and what we call designated members that we pull in from social care expertise in order to make sure we have really profound representation of the social care voice. But there's a lot happening in Gravity, and I really hope that that presentation on the different types of assessment that we pulled in helps answer some of the concerns that we had a couple weeks ago. Any other questions before we move on into the utility and security content? I see thumbs up. I hope that feels reassuring. I hope it feels like our model is trying to hold ourselves accountable, right? We do want to make sure that the ways of knowing and practicing and wisdom and expertise in the social care ecosystem are represented as we craft our solutions. All right, I think we're good. Read the report. It's really exciting. I know, I find it exciting. It was, I called it my highlight of 2023, and it really was. It was an honor to sit with experts across the social care ecosystem. The bios of all the social care experts who helped are available on that link on the Confluence as well. And all right, next slide. Next slide. This is the history of all the domains we've addressed since our inception. Again, here we are in utility and security. And again, you can see how, so we're addressing utility and security as a domain right now, but there's lots of non-domain work that's happening. So one of the things we've been working on with Gravity is as we continue to build domains that need to be built, this kind of longitudinal work, we're also deepening our work in making sure that we're addressing critical use cases. And so making sure that our systems and structures and terms are not just like adding additional domains, but also adding the ways of knowing and practicing that are critical for social care. Next slide. You can see those discovery use cases that I mentioned here on the roadmap. So here we are in utility and security. We are going to be starting coding for food either this spring or in the fall. We don't quite know when that's going to be landing. We're very excited for doing that critical work that was presented in the fall. We have these, these two use cases that I mentioned. So you can see we have the social care payment and reporting use case and the interventions, outcomes, and tracking use case. One of those use cases will become a new full use case development on the roadmap with a technical team engaged in creating those solutions and resources. So we have this discovery period, and then eventually later on the spring, there will be an actual build, and you'll see that come into the technical and terminology meetings. Along with this, we are exploring ways of enhancing our documentation of programs, both the services delivered and the structure that they're living within. And then we're planning, we just started kind of putting rubber to the road for our fall domain planning. So we can get, hopefully when we come back in a couple of weeks, we'll have not just fall domains on the roadmap, but also winter 2025 domains, because the Gravity team on terminology, we start planning for subject matter experts usually 6 to 9 months in advance. So it's really good for us to get an idea of what we're looking into. Again, there's a lot of really interesting work led by the Lantana and AMA team on revising our implementation guide. You can hear more about that on the Wednesday meetings. And again, on Thursday next week, we kick off the implementation work stream again with that conversation, learning about technical elements within screening and the New York pilot. Next slide. Okay, any questions on those long announcements? Longer than usual because of the social care co-design report. All right, if no questions, please do read the report. It represents a lot of labor. And I want to note that it represents us being accountable to what our social care friends were telling us we had to do for a very, very long time. And we're very grateful for all of them helping us to document their expertise so we can make plans to be accountable for it. Next slide. All right, next slide. So again, this is just the grounding of where we're going. Again, you can see what I was mentioning, those existing activities, right? Screening, diagnoses, goal setting, and interventions. Eventually, you'll see this model become a little bit more complicated, right? This will be adding different kinds of information and different use cases, and we might create layers of information. We have this layer of terminology, and then there might be additional layer of terminology to support things like, the program documentation and reimbursement. You can see, you don't see, there's not a HCPC code over here in interventions, but there could be. You might see holistic assessment or care planning be a use case in this circle diagram as well. So this is a representation of the activities we focused on for some time. As we add new use cases and activities, you'll see the model evolve and change along with the terminology to support them. Next slide. I think you might have seen this again, and maybe not. My apologies if I'm not remembering. This is a slide we presented to the WEDI Health Equity Gathering. This is basically what you all helped drive, and I think I did present this a couple weeks ago. Gravity is well recognized now as a standard for standard development. We have a very rigorous and consensus-based process that you all help make good. And so this is a slide that we created for the WEDI presentation, which does a pretty good job of showing how our processes, our subject matter experts, and all of your expertise and enable highly referenced evidence-based data sets that are able to be pointed to by various regulations within a degree of trust. So thanks so much for being part of this process. If you ever want to do a roadshow on Gravity, we do have, we kind of nominate anyone who's part of the team to go to presentations and take our overview slide deck, because you all are part of the community, and we want to make sure that all of you feel like you have the information you need to speak to the work we all do here. Next slide. Okay, next slide. All right, we are in community terminology development. This is in the identify phase of our work. Again, when we talk about our processes, and you saw this on the slide prior, the first elements, which we're calling now the gravity terminology curation process, are very formal. Pre-work, identification, review, vote, analyze, and build. It is a 6-month rinse and repeat process, which we now have down to an evolving science, I'll say. I say it's a science, but we're always trying to make it better. We are in the identify phase of that process. I'm just trying to make sure and see if, oh, we do have SMEs here. Great. Great. We also have some of our social care experts here. I'm going to note that we do have members of the community who are part of the Social Care Voice Co-Design report here as well. All right, next slide. We are here on the 22nd. It's our task to identify utility and security concepts. We did have some really lovely emails from members of the community who were reflecting on areas of refinement to our approach, and we really appreciate all of your engagement. If you have instruments that you feel like are critical for measuring a facet of utility insecurity or energy insecurity, please send it along. If you have programs that you feel like are important or people that you feel like are important that are not yet part of our value sets, please let us know. We're going to be doing this identify phase through early April, and then we go into end-to-end review and consensus vote. Next slide. We wanted to just refresh everybody about how to find the terminology masters. There is a utility insecurity page on the terminology workstream tree. Underneath our domain work, you can find the master list in process on that page. You can also find instruments that are under consideration or finalization. You can also find a burgeoning reference list. I want to thank our members who are always calling out populations that our references or instruments might not measure. We heard some comments from a couple people regarding virality. So we did add a rural reference on energy and security into the references and look forward to talking about that with our SMEs when we see them tomorrow for our weekly gathering. And again, all masters are posted by Friday, 5 p.m. EST, the day after the public call. It's a lean master now because we're in the beginning of our work, but you'll see it bloom with instruments and definitions and programs as we go forward. Next slide. Next slide. Our amazing subject matter experts, you can see their information on the Confluence. We have Dr. Diana Hernandez, Dr. Deborah Frank, and Dr. Stephanie Edner de Cuba. Stephanie is not here today. I don't think Debbie is as well. Oh, I see her, actually. I do see Debbie, I think. And I cannot tell you how honored we are, the terminology team. Hi, Debbie, to work with these 3 subject matter experts. As many of you are aware, the work that we do here, the soundness of our process is really built on the soundness of how we measure the domain of reference. We could not have 3 more expert people in measurement. I mean, the conversations we've been having are just so deep, and we're so grateful for these 3 experts. So thank you all, and you can read about their bios and their information on the Confluence. Next slide. Working definitions, again, working definitions, and we're going to revisit these later. We have a rough definition of utility insecurity kind of started us off. We have really some sound definitions of energy insecurity, one from Dr. Hernandez's work, and then one issuing out of the work from Children's Health Watch, which is Dr. Frank and Dr. Edner de Cuba. You can see underneath the second definition, there are some dimensions that we were talking about, like measurable dimensions that align with instruments you're going to see today. And we're going to be exploring different dimensions to make sure we have the full breadth of the domain. We'll be talking about that as we go forward. And we are ongoing trying to figure out how to address elements that are not included in energy insecurity, including water, which is part of the Children's Health Watch instrument, and then other utilities. Some of these might need to be addressed elsewhere, and we'll be learning that together as we go forward. Next slide. Again, this is our common slide to just level set. When we think about the financial driven insecurities, these dimensions of insecurity are themes that we see as we go forward. A dimension of worry, stability, quantity, quality, and cultural acceptability. You can see, again, a lot of these dimensions being part of the measurable questions and answers that are aligned with the screening instruments and the subdimensions of the domain. Again, these are just themes that we see as we go forward with all of our domains, and we're seeing them play out with utility insecurity and energy insecurity now. Next slide. We're now going to focus on early findings of the consensus from our subject matter experts on elements of screening and these dimensions, these measurable dimensions of energy insecurity specifically. Before we go into that, thank you, Deborah. Debbie is 100% correct. The Children's Health Watch is a robust resource for information. Rob's asking if access to clean water is included in utility insecurity. Rob, we are trying to figure out how to address water as a utility, which might be in this domain, compared to the general concept of water security, household water security, which starts to bring in themes of potability and, contaminants, things like, Jackson, Mississippi or Flint, Michigan. So we really are firmly in that right now. So water as a utility is part of CMS's approach to utility insecurity. Water as a utility, whether it's, threat of shutoff, is part of Children's Health Watch's screening approach. But outside of that, water insecurity as an experience or water insecurity as a global element, which involves outside of the household cost considerations that might be out of scope. And we'll figure that out together as we go forward. Luckily, our SMEs are brilliant and will help guide this work. Yeah, so they're definitely, exactly. So there's going to be a line drawn, Rob, about what is in and out of scope regarding water as we work with our SMEs and come back. And you can see, again, this coming through some of the dimensions that we have detailed already in our assessment instruments on the next slides. Next slide. All right, Debbie, I didn't check with you about the text on this, but I built these slides to center some concerns Debbie had, Dr. Frank had, regarding the requirements of setting the groundwork for screening before you begin screening. And Dr. Frank and Dr. Hernandez and Dr. Editor Cuba were all really universal on this need. And we have recognized and seen this need in other domains, so it shouldn't feel like it's a surprise. Basically the preface is that there has to, whenever you're doing screening for sensitive topics, you have to convey purpose and you have to convey safety. For those of us who were here during the intimate partner violence screening methodology, you remember the CUES model, maybe? We actually just talked about it in the fall when we were considering approaches to intimate partner violence and interpersonal safety screening. So the principles of this are fairly similar. I put some text here, but Debbie, Dr. Frank, do you want to just speak briefly to your concerns and why you felt like it was important to highlight this slide before we addressed screening instruments?
I'm a pediatrician, and so in a urban hospital with very disenfranchised patients. And so the concern is, if I disclose a hardship, will I get the protective services involved? So that's one reason to normalize it. I'm a little uncomfortable, which the third sentence, I would say there are many community resources that may be available rather than are available, because when I was practicing, we spent a huge amount of time beating our heads against the wall, trying to find resources, connect people to the resources, make sure they got them. So I don't want to overpromise.
Yeah.
And I'm sure that our community partners have real clear feelings about this too. And the other thing you can say is, even if what you tell me, I can't help you with this right now, we've put together what lots of people tell us, and we use it to work for changing the conditions or increasing the programs or something to help people who are having the same problem. But I have to be very, very careful about, I mean, I can promise you can go downstairs and use our food pantry before you go home. That's easy. But I sure as heck can't promise you a house,
Yeah.
So you have to be very careful what you convey.
That is really important. Yeah, and I just to make sure that I could reference something that people could point to, I pulled these statements from the AAP and FRAC Screen Intervene Toolkit because it had these kinds of concepts in it. You're correct in that depending on the domain, saying there are many community resources are available is problematic, especially when you're considering housing. That was a toolkit specifically for food, but I do appreciate, Dr. Frank, that you wanted to make sure that we level set this before we went into screening instruments because it's critically important. Not to put you on the spot, Diana, but Diana, do you have anything else to mention, given that this was something that you agreed we wanted to level set on before we go forward?
No, I think I support all of what Debbie mentioned, including, level setting on expectations and ensuring that people aren't set up for some, impossible thing to deliver. So yeah, I'm in support of what Dr. Frank just said.
Fantastic.
Folks, it's okay to call me Debbie. The whole world knows. It's okay. The children call me the grandma doctor, so it's really, I'm not fussy.
Any other thoughts on this level set? Again, we've talked about this level set as being a really important one, regardless of the domain. I'm very grateful our SMEs asked us to reset this here today. And again, this is a core practice of what we do in clinical settings, just to make sure people feel safe to disclose information. And those of you who work in social care settings do the same thing, is my understanding. All right, so now we're going to go into the instruments and the dimensions we've established so far. And you can see why, even though I addressed Rob's comments about water quality, again, we think about those dimensions, right? The measurable dimensions of an insecurity, right? Do I worry about not having it? Do I have enough? Right? Oh no, is it stable? Do I have enough? Is it of good quality? Is it safe? Right? So water quality is very much in that quality and safety component. Again, thinking of things like, like cities like Flint or Jackson, right? What you'll see within some of the common methodologies of utility and energy insecurity screening is the financially driven utility is often aligned and included in this approach, whereas the quality and safety questions are not, right? And so again, we'll try to tease this out as we go forward, but that's just part of what we'll consider as we go forward in our work. Gravity sits itself in sticky problems, and this is one of them. Debbie, do you want to present this slide since it's your instrument, or do you want me to?
I can. I haven't done the interview myself, although you just, I think we just say, let's talk about,
Yeah.
how you heat your household, how you cool the household. Do you or someone pay for heat, electricity, or water? Just about water, what Dr. McClure is referring to, the clean water is usually way above the individual level. It's usually a municipal problem. And whether or not you get clean water doesn't depend on whether you pay your bill, because in those horrible cities, paying your bill or not, the water wasn't safe. And so that's a different, you're working at a different level of problem and intervention. And so we need to think about talking to whether individuals are the right people to ascertain this. But anyway, to go back to this stuff, and did the child's home receive energy assistance like LIHEAP or the Salvation Army or anything else? the threatened shutoff, which I realize we do not in our city have people using propane, but I realize that those of you who work in rural areas do. So that I think has to be added to the list. And I guess some people who heat with wood also buy their wood rather than go out and chop it. So that would have to be included. Shut off gas or oil, yeah. And the other stuff is the cooking stove came from my ER colleagues who were we've seen enough bad stuff from problem-solving efforts to no heat being provided in the routine way that they wanted to make sure we asked that, because it can be really dangerous, bad for kids with asthma. And there's also what we haven't asked about, but there are a lot of really dangerous alternate methods that people use, like kerosene heaters or candles, that end up with horrendous house fires. So again, depending on where you're working, talking about problem-solving methods may extend beyond the cooking stove. And then the water shut off. But that again, that one's at an individual level, sorry. But most of it most of the water problem is at a much higher level. And it doesn't depend on an individual household's ability to pay. Does that help? I mean,
it does. And I think the important thing to note is that we do, just like we didn't address food access when we address household food insecurity, like is there community food security and community access to foods? We can conceptualize in time addressing the community level drivers like water quality. Just because it's not being addressed here doesn't mean it won't be addressed, right?
that's a good idea.
Yeah, so gravity just works in what is measurable and impactful in one layer before we go to the next, right? So we worked at what was measurable and impactful at the person level with food insecurity, and then we planned to go to the community level, right? That's on our roadmap for very soon. Neighborhood safety and food access in the community, right? Same thing here with water, right? Just because we're saying it's not a measurable dimension and intervenable in the same way as energy insecurity, it doesn't mean we won't address water as a quality issue and a community issue. It just means it's not in this set at this time. And so, Rob, that's a really good question. So one of the things I want to settle on here before we go off, and Debbie, thank you for highlighting the questions. The questions on, if you look at what we had for utility insecurity in the past, it was actually a question on, one of the core questions was the question on the Accountable Health Community Screening Module, of which Debbie was on the subject matter expert for, and she fought really hard. But you can see that in the AHC questions, they only use one of these, right? And they combined water and electricity. Right, so they just used the threat of shutoff and not the actual shutoff, and they mushed water into gas and oil and electric, right? And there's a couple different problems with that, right? So there's a problem of not having sufficient concept of severity, and there's a problem of mixing terms, right? And so you have a triage problem, you have a data quality problem, right? Or you have a problem, just an opportunity, I'm going to say it that way. So the full breadth of questions in the Children's Health Watch instrument approach really gives us more granular, actionable data akin to other domains we've had in the past, like food insecurity or housing. And Rob, just to answer, so you can see the drop-down options in the first question are a lot of the what's your home is heated by answers. So if you're trying to understand, that what is your home heated by, that would be a way to get there. Same thing as cooled by, right? We don't have the drop-down answers there, but that's where they would be. Any questions on the energy insecurity questions and you can see water's in here. It's in the energy insecurity section on the Children's Health Watch instrument. But any questions on that instrument and the approach there? And then Sarah has dropped in the comprehensive instrument that is delivered across multiple sites, across longitudinal analysis, and really robust research. You can read the whole thing. A lot of our screening approaches and across all of our domains have come from that tool. Debbie, you do a pretty great job being a SME and all kinds of things, especially a process one. Okay, so again, now we're going to talk about similar dimensions from a different lens of the tool that Dr. Hernandez and her team utilizes in their research, and you can see some themes being pulled out again about dimensions we can settle our hat on and dimensions that we are currently exploring. Okay, that was so Tom, we will talk further about, I think the thing is we're talking about cost-driven water, even if we're trying to parse out both individual and community level concerns about water. Don't please, like, we're always going to be talking, we're always going to be leaving. Hi, it's nice to see you, Tom. Appreciate you. I'm a
nitpicker. I just wanted to get that into the conversation, but I totally understand where you're going in terms of cost insecurity.
Yeah. So, but Tom, do you want to elevate what you said in the chat?
Well, I was just involved with the Flint water response as the point person for 211 between the local Flint community and the 211 system, which was where the state was directing everybody. And so got a lot of nuance, I guess would be the best way to put it. And while the fundamental issue had to do with how the city was treating the water, it was the lack of treatment that made the water acidic that caused the pipes and the connectors to individual residences to become a lead problem. And so there's a complex interplay between what is a community level issue that has to be addressed versus what could be addressed at the individual home level, whether that's, you know, somebody who owns the home who needs to understand what mitigation they can do, or if it's a rental property, what's the responsibility of the landlord to ensure safety for their residents, and particularly for the kids who, you know, are going to be suffering lifelong effects of this kind of issue. And we know that lead connectors and pipes are an issue across the country with older infrastructure. And so it only becomes a visible issue when there's something going on, like in Flint or Jackson. But this is it's a public health concern that it may or may not be appropriate to address.
My concern in terms of parallelism in these measures and in Dr. Hernandez's measures are that whereas people get a monthly bill for gas, electric, oil, even water, and, you know, buy propane at regular intervals, they don't get a monthly bill to fix their lead pipes. It's a very different level of financial and cognitive strain and in potential intervention. And so that, I think it's very important. What you're saying is huge. My colleague Sean Palfrey kind of foams at the mouth whenever you talk to him about Flynn, because lead poisoning is horrendous. But it's not a good analogy for the other things that we are working on right now. I'd be very interested in how else you could work on it.
It reminds me actually of the breakdown we had to do to approach housing specifically. And again, Dr. Hernandez has a lot of writing about housing as a mediator. So I just want to elevate some of the research she has about how the house outside of the utility bill plays into energy insecurity. So she's about to come, part of her instrument's about to come into that. But with housing, what we did is if we think again about those dimensions, worry, stability, quantity, quality, and safety, inadequate housing was separate in the quality and safety measurement, right? And intervened in a very different way than housing instability or homelessness, right? So sometimes a dimension, what we again, not a subject matter expert, but sometimes the quality and safety elements are distinct enough that we think about them completely different, like separately, right? And I'm feeling that this is kind of where we're heading, and I just wanted to note that there's precedent for considering it that way with the way we approached housing, right? Jonathan, does that make sense? Debbie? Diana?
No, I think, I mean, it's not that it's not, it's not that it's not important. It's not,
Yeah.
I don't think we're working on the right model to address it.
Yeah, okay, I'm with you. And I think we're all agreeing, we're just noting what we do. One of the things we do in Gravity is do a good job of elevating important things, even if it's not exactly the thing we're addressing now, because it holds us accountable for addressing it in the future. All right. Any other questions on the Children's Health Watch instrument? Again, this is the first time you're all seeing some of those dimensions of the domain and the measurement questions that would get you to them. And you're going to see this echoed again against Dr. Hernandez's instrument on the next slide. So next slide. And there's Dr. Hernandez's, the approach that they use in their analysis has these themes that you saw them in the questions from the Children's Health Watch instrument. I pulled them forward here because this is the way that they're structured in the appendix of the research tool. These are the points of commonality across the Children's Health Watch instrument and Dr. Hernandez's instrument. Diana, do you want to say anything regarding them?
So I basically, first of all, I'm doing childcare pickup, so forgive me if I'm huffing and puffing. But what I would say is that, of course, those are, so two things that are important, I think, to know about the differences between our questions and Debbie's group's question, is that the 6-month reference actually had to do with the COVID era. So all of the other questions are based on a 12-month interval, but because of the shut-off moratorium that was in place, we only asked about the last 6 months. The stove or oven for heat, those were a derivative of Debbie's work, and the service shutoffs as well. So, this paper basically builds on the work from a paper by Cook et al. And then we add a few more dimensions, which I think as a group we're still discussing.
Thank you so much, and yay for doing kid pickup. We all understand how that works. So the reason what we wanted to show you all is that so as we're working with our subject matter experts and we're thinking about the definitions that we have, those working definitions, you see these common core themes early, right? There's some conversation we have to have with our subject matter experts regarding additional domains and how to address them. And you'll see some comments on things we have to consider across both instruments from a rurality perspective on the next slide. Thank you, Bill. But these themes of disconnection notice, stove or oven for heat, and service shutoffs are themes across both instruments. So they'll be kind of they're working critical dimensions of the domain as we go forward. So Rob, you can see in the I think the Children's Health Watch instrument, they do ask about assistance. So in the previous slide, asking about presence of assistance is part of the Children's Health Watch approach, right? So it's the 4th bullet that we have there. And then we also, you'll see a burgeoning list of programs for intervening on energy insecurity. The next slides, we always try to include those kind of federal or state approaches in addition to the multitude of independent programs. Luckily, both Debbie and Diana are experts in all of those. We just started to touch upon it at our last Friday meeting, But you'll see those specific types of programs rolling out as we go forward over the next weeks. Any questions on, again, these common dimensions that we've arrived at right now? I'm sorry, my cat is like, it's like the end of the day, so she's like right here. And now if there's no questions, we have this disconnection notice dimension, the stove or oven for heat dimension, and the service shut off dimension. Again, noting that the service shut off is a missing element that we did not have in the current accountable health communities approach that is really critical. We missed it when we're thinking about how to build and conceptualize this domain. In our previous analysis, this was a missing element, so we're glad our SMEs are bringing questions to get us there. Next slide. Making sure I didn't miss anything.
Yeah,
Okay.
I would point out that, and I don't think it's an awful thing, that some instruments have condensed those two, so that it starts. Are you already? One of the answers is have a warning, and I'm already cut off. So I think it partly depends on the interval. But this stuff wasn't handed down at Sinai. People can work together to adapt it so it's the most efficient for the way it's going to be used.
And one of the things that we consider with getting these dimensions into the ecosystem is screening instruments are one way to get there, right? But we always take care to note that if you know the dimensions and you're having a conversation with a person and you hear these dimensions, and Debbie, you and I were talking about that with a different area, then you don't necessarily have to go back and screen them, right? So if they're saying that they've received a disconnection notice and their service has been shut off, hopefully over time we'll have enough socialized elements of core criteria that we agree upon that you can reference. Again, this isn't like ad hoc, willy-nilly. Like, this is a dimension of reference for this domain. This patient meets this in conversation. This is a concern I can identify, right? So we'll see possibly these kinds of dimensions or criteria bloom as we go forward. And that allows, again, for the fluidity that Debbie was talking about, even as we try to evolve the approaches to meet multiple needs that aren't represented here. And so this is in the next slide. And again, Debbie, Diane, if I said anything crazy, please let me know. I'm the lucky one who gets to sit with you on Fridays at 4 o'clock. And I want to make sure everyone gets to understand and learn with you as lucky as I am. Next slide. Before we move on, again, we're almost to the close of the meeting. We wanted to revisit. Oh, yes, Denise? Do you have a
Can you
question?
hear me?
Yes, I can. Hi.
Oh, okay. Here in California, we have a lot of folks living in the mountainous areas. So I'm going back to the comment about wood is an option.
Yes, yeah.
So having worked with the Native Americans and the folks living do these questions, how do these questions apply? I mean, how do you heat your home? And then, because CDPH, I shouldn't say this, we've been audited, and if we don't refer right, we end up in the newspaper. Oh, darn, it's already recorded, huh? Can you help me out, Sarah? You know my simple mind.
No, it's not a simple mind, it's an astute mind. Well, maybe simple and astute are the same. In my book, they actually are. But you can actually wait to cue us up for the next slide, Denise. And I want to again thank, a lot of what you just said was actually echoed by our friend Bill, who's on the call. Hi, Bill. We always thank you for noting rurality as a factor and the needs of certain populations that we need to consider. So Bill, thank you. So we built this slide to kind of capture some of the pings that are outside of those core dimensions we just heard. Disconnection notice.
Oh, okay.
Yeah, just a disconnection notice, stove or oven heat are actually cut off, right? Those are the three that we heard and everyone agreed on. So we pulled forward again those kind of macro definitions.
Oh, okay.
Which are really inclusive of all the things you're saying. We just don't have the dimension specified yet.
Okay,
right?
because I worked in the Midwest where on the extreme, what do they call it? Extreme weather. I don't want to belabor all this. Where
Yeah.
we asked those questions and then we had resources for the folks right in the
Yeah.
Midwest. But then here in California, like I said, there are some folks that's all they have is wood. So,
Yeah, I mean, I practice in rural Vermont.
that's
Yeah.
right. Yeah.
Yeah,
Okay.
yeah. Most of my patients survive on wood heat.
Yes.
No question.
Okay, so I'll sit tight.
Yeah, but don't sit tight. Keep on raising your concern because otherwise we
Okay.
won't get it right. Always raise
Okay.
your concerns. Great. Help us get it right. So, oh, sorry. If we go back, I just want to go back because we have our two definitions. Again, one's from Dr. Hernandez's work, this inability to adequately meet basic household energy needs. Yes, yes. Yes, so Debbie's elevating everything you just said, that they acknowledge that the urban focus of the Children's Health Watch instruments and really looking for understanding other instruments. And we have some instruments actually in the hopper for SMEs to assess that are used in rural populations, so we'll get there. And then you see the Children's Health Watch definition here, limited or uncertain access to enough home energy to sustain a healthy and safe life in the geographic area where households located. That definition is also inclusive of rural perspectives. We just don't have the questions to get you there yet, right? Whether it be the type of heat, or whether it be some of the drivers and effectiveness. We'll figure that out in time. What we want, again, this is an iterative process. It's consensus based. All of you help us get it right. We are grateful for your expertise. What we wanted to say is our future work, just to be accountable again, is that we're considering these other dimensions. Dr. Hernandez has a host of other dimensions in her work in the energy and security indicator set that we'll be further discussing as we go forward to see whether we should bring them back. I want to note that Dr. Hernandez in the research study that was published prior to the couple Tuesdays ago in Health Affairs, prior to the last call, this kind of groundbreaking study, that question that was part of that study on the whether the medical device that a person is using has been affected by energy insecurity is a question that everybody, all of the SMEs agreed is really critically important, and they want to figure out in the indicators, but also in the question approach. Debbie and I were talking about that's like what I do and like how I intervene most often besides connecting to LEAP in clinical practice. I have a template for how an energy shutoff will threaten the health of my asthma patient who uses a nebulizer, or my COPD patient, or my patient who is a pediatric high-risk patient who's dependent on energy related, devices to sustain their life, right? So that Dr. Sarah, I've got a threatened bill from the utility company. Here's my, account number. Drop an account number, defend the boundary. That is what I do most often just to try to prevent shutoffs, right? So that question was a really critical one that we saw in Diana's work. And so we're going to be figuring out how to center that as we go forward. And then the last thing, again, was what you just mentioned, Denise, and what Bill mentioned in questions. And we have a new resource that we put in the Confluence, which is really how to consider energy and security measurement in rural populations. So we're not simply focusing on urban environments, whether there's question adaptations, whether there's source adaptations, and we will work that out as we go forward. Yes, and so I want to suggest that you read the beautiful paper that Dr. Hernandez wrote, because you are right on the money, or maybe you don't need to. A lot of the references that we have on the Confluence talk about the intersection of housing quality and energy insecurity. And Diana, I don't know if you want to say anything to that. I don't know if you can see in the chat, but Tom's saying, in work on previous domains, we've discussed X insecurity due to different drivers. In the energy and utility insecurity domain, one of the drivers is related to inadequate housing. Specifically, poorly insulated housing, increasing the cost to meet energy needs. And Diana is like, she's not, I'm sure she's echoing everything you have to say. We could address this utilizing multiple IT social need codes, or by including weatherization assistance and related services in the list of interventions. Tom, thank you. Diana, do you want to mention anything, given that this is your area of expertise? Or are you picking up kids? She might be in kid mode. She did have to pick up her daughter, but Tom,
Oh, sorry.
Yeah.
I heard most of what was said, and then I saw what was on the chat. Sorry, I was on the bus, but
oh,
so
I love it.
let me let me just say that basically, yes, absolutely. This is so energy insecurity, and that's rooted from in the definition, is kind of broad, and it's not just focused on the economic domain. It has a physical component, which is very much rooted in housing. And the way that that's distilled in the in the 10 indicators is really about extreme indoor temperature. Of course, that wouldn't be the only way for us to understand it, right? It could be need for repair on certain kind of like the heating and cooling, or even refrigeration or other kind of necessary appliances. And we have those questions in the broader survey, but we wanted to, for the purposes of just kind of setting out an example of what a broader vision for and quantification of the energy insecurity indicators would look like. We kind of have under the physical domain just extreme heat or cold in one's home. So there's room for improvement there, and I think even along the lines of acknowledging and recognizing electricity dependence for folks that electric medical devices. The same thing would be kind of true around other household appliances, and or the conditions around drafts and poor insulation that really feed into the experience of energy insecurity. So I'm in total agreement, and also realizing that at some point we had to we weren't as inclusive as we would have liked to be, because this was just in some ways like a proof of concept around expanding the measurement and the indicators used.
Thank you so much. But Tom, just want to know, yeah. Any other comments there?
No, disagree.
Yeah. So Tom, just want to, you had your finger right on the pulse of it all. Yes, exactly. We do address intersectionality sometimes in our SNOMED CT terms. We think about like transportation insecurity, influencing access to healthcare, right? So even though the IC10-CM diagnosis, we try to keep kind of distinct.
Mhm.
I will note that the current IC10 diagnosis is in inadequate housing, because that's where the CDC put it, inadequate housing utilities, right? But that intersectionality, we, in a limited way, without too many ands, we do try to build into our SNOMED terms for exactly this reason, like energy insecurity driven by inadequate housing quality or something to that effect, right?
I'm wondering, and again, this is really more for future discussion. I don't want to sidetrack us too much today. Perhaps just a more generic ICD-10 code that is something like social needs related to boom, 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 insecure housing, inadequate food, and so forth, so that there's something that says this person has multiple needs that are all somehow related.
You have your IC10-CM experts on the call. We also have your SNOMED CT experts on the call. All of them are listening. Little do you know. So we'll try to figure out a path forward on that. But again, the intersecting nature of these things is definitely what we sit in with a gravity on a regular basis. And I'm so glad you all remind us of that all the time. And Debbie, thanks for the the radiator comment. I live in an old Victorian house with radiators, so I note this. And I remember visiting my aunt in the East Village. She was a plumber in the East Village, and the co-op radiator predicaments. So just noting that to be true. All right. So I hope in this last slide, we're pulling in some of the themes we've heard that you all want us to keep on considering. You heard Diana mention some of these other questions that talk about what Tom was talking about. You heard both Debbie and Diana and myself talking about this medical device element. And then we are all talking about how to consider that we are inclusive of measurement in rural populations. I want to pull back in. We talked about what is water insecurity insofar as utilities and what is water insecurity that might be more quality and safety related as we consider the community level domains. Any other questions before we move on? Next slide. I think we're there. Next slide. Oh yeah, oh no, sorry. We have one more slide. Next slide. This is a very early list. We focused on agreement on the core dimensions that were across the two instruments last week in our SME gathering. This is a very early list on those programs, professions, and roles. Rob, you started to mention them. There'll be a lot more, I imagine, when we come back in 2 weeks. You see the LEAP here. We also are leaning into the non-standardized LEAP-based forms of utility assistance, including utilities itself offering assistance. You'll see all of those kinds of programs blooming over the course of the next couple weeks. We're not putting down all of the general interventions like refer to case manager, refer to area agency on aging, refer to a community action agency, because those we just repeat every single domain. They're all social risk interventions. So we're not going to put them on the slides for you all to see. You'll see them in the master list. They just won't be on the slides. Any questions here? Again, early, but it was what we were able to get to at the end of the week last week. Yes, next slide. And we had a great conversation regarding different types of utility use and sources and how they affected cost. This is where we kind of got focused on our time last Friday, is understanding how different types of energy have different costs associated with them, and then further impact and accentuate insecurity. So you get into this vicious cycle. Any questions before we close the meeting? It's been a good one. Next steps. Again, I hope you see those of you who wrote emails and had comments that we read them and centered them. Keep on sending your reflections, either general reflections or specific programs, ideas, anything you want to add. You can always catch up on materials. You can review the recording later on the Confluence and submit screening instruments that you feel like we need to reference. If you find any specific rural focused screening instruments, please send them our way. If we can mobilize our crew to make sure that we're capturing that effectively. And any programs used to intervene, please let us know. And any unique people's roles, professions, and helpers. Next slide. Come join us. We'll see you in 2 weeks. Please join the technical workstream meeting 1 to 2 Wednesdays every other week. And again, really exciting. Next week is our first pilot affinity group kickoff for the implementation workstream. Again, we'll be focusing. It's a tech fun meeting focusing on observation and questionnaire response in the New York pilot. Thank you so much, friends. Have a lovely Thursday evening, and we'll see you in 2 weeks.
Thank you, Sarah.
Bye, Tom. Bye, everybody. Thank you, Diana and Debbie.